Good evening, everyone. Welcome to another Surge Kuwait Surgical Fix series. Today, we are honored to have Dr. Sinziana Dimitra as a guest, where she will be discussing GIST. Dr. Sinziana is an assistant professor at McGill University in the Department of General Surgery. Before we start, if anyone has any questions, you can type them up in the Q&A panel, and we'll be sure to address them at the end of the session. Also, make sure to register to our future sessions in the chat where the link is available. Dr. Sinziana, the mic is all yours. Is it possible to just mute yourself?
Yes, that's what I was trying to do. Hi, my name is Dr. Dimitra. I'm a surgical oncologist at McGill University, and I have an expertise in sarcoma as well as gastrointestinal stromal tumors, or GIST. So today we'll be talking about GIST. These are basically new tumors that have been named in 1983, and they're originally used to distinguish tumors that are not of epithelioid origin. And as immunohistochemistry became more prominent, and we discovered that there was a specific mutation and immunohistochemistry marker that was available to diagnose them, which is CD117, it became very clear that they were very, very different from other lipomas, liposarcomas, as well as leiomyosarcomas, which are other common tumors of the gastrointestinal tract that appear in that area, mainly in the submucosal fashion that are either pedunculated or in the wall of the small bowel. However, they remain still very rare. They are the most common sarcomas of the abdominal tract, but they still remain very rare. They only represent 0.2% of all cancers. And it's very important that they remain treated in a multidisciplinary team that has experience with sarcoma, because as you will see, the picture of GIST has become more and more complicated as we made further discoveries. It remains a surgical disease. So these tumors originate from the interstitial cells of Cajal, which you can see here, that are located in the wall of the small bowel or the GI tract. And the role of these cells is to act as a pacemaker of the gastrointestinal tract. They generate these slow electrical waves, which promote contractility, and that is their role. When they become mutational, these cells can develop into GIST or cancer cells. Sorry for that technical difficulty. The location is very variable. So most of your GISTs are going to be located in the stomach and the small bowel, with 60 and 30% of them located there. Much more rarely, we're looking at the duodenum in 5% of cases and the rectum in 4% of cases, less than 1% of the esophagus and the appendix. In fact, they're so rare that they're not even often discussed in the appendix at all. In terms of presentation, most of these cases are now discovered incidentally because we have access to high-grade CT, to high-quality CT scans. The symptoms are usually vague and they really depend on location. So for example, if you have a GE junction tumor, the patient could present with early satiety, with obstruction. If the tumor is very large and has grown into the retroperitoneum, the patient can present with abdominal distension, increase in abdominal girth. And one of the more common presentations is actually gastrointestinal bleeding, which can present in the form of a patient that comes with a severe upper or lower GI bleed, or in the context of anemia, which is more of a slow-growing bleed. Some of the patients might also present with fatigue, which is more of a symptom of the anemia than anything else. And very, very rarely, the patients can present in acute abdomen. That occurs either when there's a spontaneous tumor rupture, secondary to either necrosis, or when the tumor bleeds intraperitoneally, again, secondary to necrosis and tumor rupture. So this context is very, very rare, but it's possible that you might encounter a patient as such. Where do these tumors metastasize? So most commonly, like most of the other tumors in the GI tract, they metastasize to the liver. Very rarely, they can present with peritoneal sarcomatosis, and sometimes they also can present to the nodes. Presentation to the lymph nodes is extremely, extremely rare. We're talking about less than 1% for a very rare tumor already. And they're really related to very specific subtypes, which we'll discuss later. And by subtypes, we mean similar to breast cancer. We are now categorizing breast cancer based on the ER/PR and hormone receptor status. We're starting to categorize GIST tumors based on their mutational pattern. And we'll discuss that a little bit further. Most of GISTs are sporadic, but you have to keep in mind that there are certain genetic mutations as well as genetic syndromes and triads where this can occur. So you can have NF1, which is neurofibromatosis type 1. You have a lot of patients that can have GIST, and in general, they present with multiple GISTs along the small bowel as their presentations. As you will remember, patients that have NF1 mutations tend to have sarcomas early on in age, usually leiomyos or angiosarcomas, and as well as MPNST or malignant peripheral nerve sheath tumors. And they also can present with multiple subcutaneous nodules, as well as the typical café au lait spots that are seen. In the Kearney's triad and the Kearney-Straczynski syndrome, these we're looking at patients that have SDH deficiencies. So basically, they're lacking the SDH. Because of the lack of SDH, they present with, in addition to GIST, they can also present with paragangliomas. And that's extremely important when you're operating on a patient that has a paraganglioma, because if on top of the paraganglioma, the patients have a GIST, then you have to also test to be sure that the patient does not have an expression of catecholamines or metanephrines. And similar to a pheochromocytoma, you don't want the patient to go into an acute pheo attack while you're operating because you didn't actually check that the patient had a paraganglioma. So again, very rare, less than 1%, less than 5% of cases originate from a genetic mutation, but it's important to remember that they're there. In terms of the differential diagnosis, so whenever you see a mucosal or a submucosal lesion located either in the stomach or the small bowel or even the rectum, you have to think about what could this possibly be. And of course, it can be a lipoma. In general, it won't have the same appearance on a CT scan. It might have the same endoscopic appearance, but not the same CT scan or ultrasound or EUS appearance. You have to differentiate from a leiomyosarcoma of the intestinal tract or the mesentery, meaning that if on imaging, for example, you see a tumor that's arising and abutting the small bowel wall and it's extending into the mesentery, that does not necessarily mean that this tumor originated from the submucosa as we described earlier. This could be a mesenteric tumor that is involving this area. So important to differentiate the chicken versus the egg, and also to rule out a potential dedifferentiated liposarcoma of the mesentery, which can also occur in that area. So if it's from the wall, leiomyosarcoma. If it's from the mesentery, it can either be a dedifferentiated liposarcoma that has that more dense appearance on CT scan, or a leiomyosarcoma. In terms of immunohistochemistry, it's really important to realize that GIST has really been revolutionized by immunohistochemistry. And what is really immunohistochemistry is when we attach certain antigens with a stain, and we look under the microscope and see if there's a staining or there's no staining. It's extremely crucial in helping us differentiate tumors. That's how pathologists can tell you that this is this type of tumor as opposed to another. It's not just based on the spindle cell appearance of the tumor, which for a GIST you will see under the microscope, but it really helps you make that difference. Very important to not confuse staining on immunohistochemistry with a mutation that appears through detection of a genetic mutation. We'll talk about that later a little bit. So most of the tumors, you guys know, have 95% of cases have c-KIT positive, 95% of them. DOG1 is the other one that's very common in 95% of the cases. And the utility of DOG1 is when you will have a c-KIT negative tumor, you're going to be able to assess that this is a GIST if the DOG1 is positive. CD34 is present in 70% of the cases, and smooth muscle actin in 25% of them, and Desmond in less than 5%. These are SMA and Desmond are usually tumors that are more associated with leiomyosarcomas or muscle or tumors originating from the muscle. So this is what a c-Kit stain would look like. So on immunohistochemistry, this is your regular slide. Then you add the antigen with a dye associated with it. And you can see here that there's browning in the region, and that will tell you that this is a c-Kit positive tumor. And that will help you differentiate from the spindle cells that are located here, from a leiomyosarcoma, for example, which would be negative for c-Kit with a GIST. Now, for the DOG1 mutation, you can see here, this is your GIST. It's much more cellular compared to the other GIST that we saw here, where there's less cellularity. The cells themselves look more abnormal. Their nuclei are smaller, and they look more collated together. This is a much more aggressive GIST, for example, under the microscope than the previous one that we showed you. In this GIST here, when they did the c-Kit immunohistochemistry, you can see that it's not staining at all. It's not dark at all. It's really blue. Whereas when they added this DOG1 immunohistochemistry, you can see here that this has become much more blue, and this will tell you that it confirms the diagnosis of a GIST. In terms of the mutations, so it's important to know that, and I'll show you the next slide because I think it's easier to identify things here. So this is the KIT mutation, which is a tyrosine kinase, and this is the PDGFRA, which is the platelet-derived growth factor receptor A. And these are the two mutations that you guys need to remember. So again, c-Kit11 is the most common mutation at exon 11, sorry. Mostly specific deletion 11 is the most common mutation at all sites. KIT exon 9 is the most common of the intestinal GIST, or the small bowel GIST. And then PDGFRA exon 18 is more common in the gastric GIST. And because nothing can be that simple, PDGFRA exon 11 also has different subtypes of submutations that can occur. You can have a wild-type GIST in 10% of the cases, and that means that there's no detectable c-Kit or PDGFRA mutation. And for those patients, it's more often that we have a succinyl dehydrogenase deficient GIST. And again, you guys remember that we spoke about that at the beginning. So you guys can see here that exon 11, which is the intracellular component of the cell, is the one that's the most commonly mutated. And PDGFRA A is the more rare subtype, but it does occur in about 6% of cases. So how do we diagnose this? It's very important to realize that most of the cases are going to be diagnosed incidentally, either via endoscopy. And if you have endoscopy, you should go ahead and if in your center you have an EUS, you should perform an endoscopic guided ultrasound. This allows to minimize the amount of contamination that you would have if you were when you're performing the biopsy versus if you do a transabdominal biopsy. Your best friend in a case like this is going to be the contrast-enhanced CT scan, which is the imaging of choice, because it allows you, one, to assess where the tumor is occurring, how large it is. It also allows you to have an adequate staging. If this is a high-risk GIST or high-risk stratification GIST, the mutations are going to, a CT scan of the chest or an X-ray of the chest is also useful, because that will be another site of a potential mutation. And more we're moving towards the PET scan as a tool to help us diagnose GIST. Very important to realize that the PET scan does not replace this contrast-enhanced CT scan. But it does have its utility because, one, it will help you diagnose any additional metastases, either intra-abdominally or in the liver. And it would also help you establish whether you have a response to adjuvant or neoadjuvant treatment, or even palliative treatment. What does that mean? Basically, your GISTs are going to be the most high SUV intense sarcomas that are out there. They can have SUVs up to 24. If they're very, very, very active, very large, you're going to see a high intense uptake in the sugar that you're injecting through your PET scan. If you start your treatment and your tumor responds to the treatment, within 2 weeks approximately, you can already see a decrease in the metabolic activity on PET scan. So there are studies out there where people have repeated the PET scan, and you see a decrease in your activity, and that will tell you that the tumor is responding. So you're ensured that you're on the right track before you even start seeing a decrease in size of the tumor itself. So that's another utility of the PET scan. In fact, the recommendation is that if you're going to start treatment in the metastatic setting, you should always have a PET scan. You should have always done a PET scan beforehand. So very important, and this is kind of new because when I was a resident, for example, we were not necessarily biopsying GIST. If it looked like a GIST on EUS, if it looked like a GIST on scan, we would not necessarily biopsy it. But as we're discovering that the treatment can be very different depending on the mutational type, we're realizing that biopsy is absolutely necessary before starting any systemic therapy, and it would be really ideal if you can obtain it before proceeding to surgery. Again, as we discussed, EUS guided biopsy is really ideal, especially because these tumors are very friable, they're at risk of rupture. So you want to avoid having, for example, an intraperitoneal bleed secondary to a rupture that would actually necessitate for you to take the patient to the operating room if you're unable to embolize. So you want to avoid all uncontrolled setting. If you need to start systemic therapy, though, and there's no way that you can do an EUS guided biopsy, then doing a percutaneous biopsy is recommended, but it has to be done in a controlled setting with an interventional radiologist or a diagnostic radiologist that has experience in performing these. And as opposed to sarcomas, where you want to use a really high true cut core, 14 gauge, you can use a smaller coaxial biopsy. Again, if you can, you should always use the sheath of the biopsy, and it should be done in very controlled circumstances. So in terms of principles of surgery, you have to realize that the only cure, as for most sarcomas, remains surgery. And whenever you perform a surgery for these tumors, the aim is really to go and have negative resection margins. And most of these tumors have a pseudocapsule that's involving the entirety of the mass, and you want to remove the entirety of that pseudocapsule. You don't want to enter it, meaning that you should not see the fleshy component of the disease. You should only see that sleek, kind of shiny capsule that covers it. Very important to handle these tumors with care. They're very friable, they're fragile. You do not want to risk rupturing them, because at that point you almost 100% condemn this patient to receiving imatinib for a long period of time, even though they would have not necessarily needed to get it otherwise. So the rate of sarcomatosis is fairly high, important to perform this in a very controlled setting. And the most important thing is to protect the integrity of the pseudocapsule, as we discussed. Now, if you're looking at the CT scan and you're assessing this large mass and it looks very large, it looks like it's involving other organs, it looks like you're not just going to have to resect a little, either, for example, a wedge because it's hanging off the stomach, but you probably are going to have to perform, for example, either a total hysterectomy. Very, very important to consider a neoadjuvant treatment beforehand. Sure, we can all do big surgery. That's not the question. The question is it going to help the patient? And if you can actually downstage it with targeted therapy, with imatinib, that really would be ideal, because it works well and it will make your surgery easier, and it would significantly decrease the morbidity that the patient will endure after surgery. Again, lymphadenectomy is not necessary. The incidence of lymph node metastases is very low. So for example, let's say that you're resecting a small bowel neuroendocrine tumor, you're going to want that pie of the mesentery when you resect it. For a GIST, is not necessary. All you need is the mass itself with negative margins. The only time that you're going to go ahead and get as much lymph nodes as possible, so perform a cancer operation like we would for adenocarcinoma or for neuroendocrine tumors, is if these patients have SDF deficient GIST, because as we discussed, for these patients, there's a little bit of a higher rate of neuroendocrine tumors. I personally have only seen 2 patients with lymph node metastases, and both patients were SDH deficient. And for both, we needed to do a lymphadenectomy. One of them, we were not back then we were not testing for SDH. And when the patient recurred a year later, we discovered that patient had SDH, and we performed a completion lymphadenectomy at the time of surgery. So now for surgery. How should you approach this? Should you do it open? Should you do it laparoscopically? Again, this has to be performed by people that have experience in sarcoma. It cannot, anybody can do a wedge resection, but you have to do it properly, and it has to be done to minimize recurrence. So very important that you use laparoscopy judiciously. For example, if your tumor is 15 centimeters in size, yes, you might be able to do it laparoscopically, but this is not a question of being able to do it. If you're going to have to increase your incision after you've done this surgery just to retrieve the specimen, then perform it open. It's going to be faster for the patient, and it's going to be more controlled, and it's going to decrease your chance of recurrence. It's really ideal for small bowel and gastric GISTs, and it's really associated with a shorter hospital stay and lower morbidity. Of course, if you're able to proceed laparoscopically, most likely the patient also has a smaller tumor. So there's always a bias in the studies that that say that we should go ahead with laparoscopy. Important for you to understand the patient selection criteria in these studies, and to look at the size of the tumors resected. So, for example, there's a meta-analysis of 19 studies published in Surgical Endoscopy in 2015 now. And it showed that the patients that were performed laparoscopically had a lower blood loss, had an earlier time to flatus, had a decrease in overall complications, especially the ones associated to the wound. And there was no associated with long-term oncologic outcomes, meaning that patients that underwent laparoscopy did not necessarily have worse outcomes. But again, if you look at the average and the median tumor size and the risk stratification, these were very low risk tumors that are easily resectable. So you can perform laparoscopy if you're an experienced surgeon. Always put your specimen in a bag. You cannot retrieve this without a bag. That's actually very dangerous, because you can actually have tumor spillage when you retrieve the tumor. You can have a break in the capsule, and if you're trying to withdraw this through a small incision, or to a small extraction port, you're increasing your risk of spillage after you've completed a perfect operation. You'd never want to piecemeal the specimen. Similarly to uterine sarcomas, piecemeal can actually lead to delayed recurrences that produce sarcomatosis. And again, if you feel that at the time of the surgery, the pseudocapsule is threatened, you're not going to be able to retrieve the specimen in its entirety, then there's no shame in converting to open. You have to be sure that you're able to apply the same principles as in an open procedure. If not, perform an open operation. So when can you avoid surgery? Are there cases when we can avoid surgery? So there is of course, if the patient overall status precludes them from surgery and the mutational pattern is favorable, you can potentially avoid surgery in those patients, because they might have competing risks where, for example, they have a high rate of dying of their heart attack that they just had 2 weeks ago than of dying from their GIST. In terms of which patients can we actually avoid surgery completely, independent of their overall status, there's a move towards these incidentally discovered small GISTs, smaller than 2 centimeters, with absolutely no high-risk features, meaning a very low mitotic rate, a very favorable mutation pattern, and that have a biopsy-proven low-risk features, have no EUS high-risk features, meaning that they have no irregular extraluminal border, they do not have a heterogeneous echo pattern when you look with the EUS, and there's no evidence of cystic spaces. There is evidence that maybe these tumors, if we left them alone, nothing would actually happen. They might not necessarily transform into aggressive GISTs or take over the patient. So in those patients, you can consider, if the patient absolutely wants it, you can consider not offering surgery, but you have to have a close surveillance, meaning every 6 months or 3 months, depending on your comfort level. You have to perform either an EUS guided imaging or a CT scan, or both. And this has to be done, again, by a very experienced endoscopic ultrasonographer, because there's a lot of interobservational biases that are occurring. So it should be always either the same person or someone of similar experience that continues to surveil this patient. And maybe in those cases, you can potentially avoid surgery. And if there's any sign of growth, you should proceed to surgery. Now, when should you give neoadjuvant treatment? Meaning you have a patient that's sitting in front of you. When would that patient benefit from a treatment with imatinib? The principle behind neoadjuvant surgery, as you guys are becoming aware now, is that you're trying to downstage the disease, meaning that you're not actually expecting to see a benefit in terms of overall survival. You don't think that the patient is going to live longer because you gave the patient neoadjuvant treatment. What you're hoping is to decrease the extent and the morbidity of the surgery. Similar to breast cancer, you're trying to, for example, avoid a mastectomy. That's why you're going to give neoadjuvant treatment, or you're trying to avoid an axillary dissection and convert that to a sentinel lymph node biopsy. Exactly the same principle applies to GIST. And this is actually one of the few tumors, the few sarcomas where this is something that is applicable, because we have a very effective treatment against it. So which specific clinical scenarios can we think of that this principle applies, especially GE junction tumors? You want to avoid a total gastrectomy. Maybe you're going to be able to render something that's extremely large, encroaching on the GE junction. You can maybe avoid a total gastrectomy. So if you can transform this downstage into something that becomes wedgeable, then that would be ideal. In the duodenum, as D2, you want to try to avoid a Whipple. It has a high morbidity and also high functional effects. So if you can proceed to just performing a side or a wedge of the duodenum and a primary anastomosis, or that would be really ideal compared to performing 3 anastomoses. In the rectum, you want to avoid an APR at all, if possible. And even if you are to proceed to an APR, you always want to do a sphincter preserving APR, because as opposed to other sarcomas, this is one where you just need negative margins. If you've performed whatever surgery you've performed and you have positive margins, there's no indication to go back and resect more. The problem is that if your margins are positive and there's tumor that has been left behind, the damage has already been done, and you going and scraping the small bowel or scraping the mesentery is not going to yield to a better overall outcome. So try to do the surgery from the first time around, do it right, and if you need help, put all the chances on your side by giving the patient neoadjuvant treatment. So based on what are we offering patients neoadjuvant treatment? Important to realize that these are all small studies that show a benefit. And again, when we're talking about small studies, we're talking in the world of sarcoma, really small, meaning 19, 21, 90, even less than 100 patients. So think about something like that in cardiology. We would never actually proceed to following the indications. But because these tumors are rare, we're willing to accept a lower number of patients and use that as evidence. So the main pitfall of all these neoadjuvant treatment studies is that the patients received neoadjuvant, meaning before surgery, imatinib, and they also received adjuvant imatinib, meaning that they also received treatment afterwards. So it's very difficult for us to tease out in these studies what is the actual benefit of the patients that have received neoadjuvant treatment versus those that just received adjuvant treatment afterwards, especially considering that the numbers are so small. But what these studies consistently describe is that there is an increase in resectability, meaning that there's a higher chance that when they went in looking at a very large tumor, higher chance of actually completing the surgery and getting all the tumor out. And there's also an association with a decrease in morbidity, meaning that the patients had a lower chance of having high multivisceral surgery, high risk multivisceral surgery, and a low risk of having long-term complications. As you can imagine, to just do a wedge of a duodenum is a significantly low risk than to proceed to a Whipple with all the leak, the gastroparesis, and all the other side effects that entails. Why? Now, you've done your surgery, you're successful, you've got negative margins. Which patients are you going to give imatinib to? And that's very important, because sometimes maybe in your centers, people might not be aware. You, as a surgeon, have to be empowered, have to have the knowledge, and have to guide treatment, because remember, GIST is a surgical disease. So important to know that even though you might be the best surgeon in the world, you perform the best surgery possible for GIST, you're the world expert, 50% of these patients have a chance at 5 years of having a recurrence or a metastases. And these patients used to die. So before 2009, when we really published the first randomized control trial looking at the use or retasking of imatinib, which is a c-KIT inhibitor, originally designed to treat leukemia, when it was retasked to GIST, we realized that the patients that were dying of horrible death were actually saved and had a very high chance of cure, or at least maintenance of a good performance status on this treatment. So that's for the metastatic setting. In the adjuvant setting, when should you give treatment? So we based our findings based on the Mietten criteria. Mietten is actually, Dr. Mietten, I should say, is a pathologist that really is the one who started the immunohistochemistry, the c-KIT mutation, everything that I showed you in terms of the stratification and the identification of GIST as opposed to other sarcoma type tumors. He's really the leading force in it. And he's basically looked at his studies as well as other patients. So original Mietten criteria developed on more than 1,000 patients, assess that size, mitotic count, and location of the tumor increase your risk of recurrence. There's also the concept of a tumor rupture, either intraoperatively or spontaneously, that increases your risk. And there's a thought that these patients should maybe be treated long-term. So prior to certain studies, we were treating most of the patients that were ruptured as high risk. With the advent of more specific tumor classifications based on mutational patterns, we're realizing that maybe tumor rupture might not be such a high risk as we thought. It is a high risk, but not in all tumors. So the guidelines currently, if you look at the NCCN guidelines, they recommend postoperative imatinib for incomplete resection for primary GIST with postoperative imatinib for patients that are intermediate or high risk. And the imatinib should be given for 36 months, especially for patients that are high risk. So, based on what do we base these recommendations? So, very important that when you guys look at the literature and you decide that you're going to use a trial or the results of a trial to guide your practice, you have to understand how was the study done. Which patient population did they target? How did they stratify their patients? What was the intervention? What happened in the control group? How long did they follow these patients for? And basically, what are the results? And did they perform any other secondary analysis that are published either in the paper itself or in additional studies? So the ACOSOG Z9001 trial, which was published by Di Matteo, the Sloan Kettering group led this in 2009. They demonstrated that through the 2000s, they recruited patients through a phase 3 double-blind study. And their patients were high risk. And at that time, high risk was defined as 3 centimeters or larger. And they were all primary resected GIST with R0 or R1 margins based on the sarcoma literature. The intervention was basically postoperative imatinib, 400 milligrams for 1 year. The control was just placebo. And this is what we were doing prior to imatinib even existing. And the follow-up was 74 months, which is a fairly long follow-up for a study of this kind. And they discovered that the recurrence-free survival, meaning that the time until the patients had the disease come back, was significantly higher in the imatinib group. And you're looking at a hazard ratio of 0.6, which is fairly high. That basically translates into a 40% reduction in the recurrence rate at 5 years in the patients that received imatinib, which is pretty huge. And the secondary analysis, they went back and they looked at the specimens that they had harvested from this trial, and they looked at the mutational patterns, and they realized that patients that had the KIT 11 deletions, as we discussed, exon 11 deletions, were the ones that responded the best. So based on this, we should at least give a year of imatinib to high risk or intermediate risk tumors, okay? Then the Scandinavians, because they do design the best trials out there, designed the Scandinavian trial SSG 18. And this is, again, a phase 3 study. They looked at a more modern description or definition of high-risk GIST. They basically stratifized on mitotic rate, more than 5 mitoses per 50 millimeter high power field, size, more than 5 centimeters, and they divide gastric to non-gastric subtypes, the non-gastric ones being the higher risk, and they also use the concept of rupture. They had a higher number of patients. They had 200 patients in each group. Their intervention was 36 months versus 12 months of imatinib, and their follow-up was 90 months, a bit longer than the other trial. And what did they identify was that at 5 years, the recurrence-free survival was 71.1% in the treatment group. So if you gave treatment for 3 years, you had a lower chance of recurrence, and the overall survival was also better, 91 versus 85%. So these results are very encouraging for us to give at least 3 years of treatment. Secondary analyses of these trials demonstrated pretty much the same thing as the other study, demonstrating that patients that had c-KIT11 benefited from deletions, benefited from therapy more than the others. But in this trial, they did not actually demonstrate that there was a difference in survival based on mutational pattern alone. And then there's a PERSIST trial, and this is a phase 2 trial. So the phase 3 trial basically looks at efficacy. The phase 2 trial is more of a tolerability and benefit added. So this was a trial that was conducted by Chad Raut, who works at the Birmingham. And basically what they identified is they took patients that were intermediate or high risk GIST, and they gave them 400 milligrams of imatinib for 5 years. Again, the data was not stratified based on mutational pattern. They did do a secondary analysis based on the mutational pattern, because as the study was progressing, they were realizing 5 years later, now we're using mutational patterns, we should reanalyze our data based on that, and they did include it in the trial. So what they found was that at 5 years, there were no patients with imatinib tumors that had the imatinib sensitive tumors that recurred. And imatinib sensitive tumors are basically the ones that have exon 11 mutations, and the ones that are non-PDGFRA V, and we'll discuss that in a second. And in patients in whom recurrence occurred, it was patients that had stopped their imatinib during the study because they could not tolerate it, either due to diarrhea or because of the financial burden. Within 2 years of discontinuation, they actually they recurred within 2 years of discontinuation. So it's important to keep that in mind, is that if the patient is going to recur, he or she will recur fairly soon after discontinuation of treatment. So what's the impact of the mutational status on the response? So there's a few other studies on this topic. There's the French sarcoma group, and I won't go on over the details of the trial, but the idea is that they identified that exon 11 mutation was an independent predictor of progression-free survival. So basically, patients that had the exon 11 mutation tended to live longer and recur significantly later when compared to patients that did not have a targetable tumor or had an exon 9 mutation, a KIT exon 9 mutation, of course. And another European study also demonstrated that they had improved outcomes in high-dose imatinib, basically comparing 400 to 800 milligrams per day in patients that had exon 9 mutation. So we thought at the beginning that maybe patients with exon 9 mutation might not benefit from imatinib, but lo and behold, this study demonstrated that they do benefit from imatinib, but they benefit from imatinib at a much higher dose, a double dose. And with that, there is a relative risk reduction of about 61% by doubling the dose in this patient population that tended to do fairly poorly compared to the exon 11 counterpart. So what about this famous PDGFRA D842V mutation? So you guys remember, if I go back to the very beginning, so you guys remember that exon 18 PDGFR is a fairly common mutation. And most of them will respond to imatinib. However, this particular mutation, D842V, does not. So it does not respond to imatinib. It does not respond to sunitinib. It does not respond to most of these treatments, except for avapritinib. And even then, it responds more poorly than the other tumors respond to imatinib. So they took this international study. They looked at all PDGFRA mutations. They identified 31 patients that had this mutation, D842V. And look at that, none of them had a response. at all. So it's as if we were giving this fairly expensive drug for absolutely no reason. And 21 out of 31 had disease progression. And when we look at progression-free survival, basically after 2 months from surgery or from observation, the patient's progressed, as opposed to almost over 2 years in the other PDGFRA mutations. So again, very poor prognostic factor. These patients have to be evaluated more serially. They have to be evaluated more carefully, and they have to be assessed, for example, every 3 to 4 months, as opposed to every 6 months or yearly for follow-up, because you want to be sure that you're able to intervene sooner rather than later. And for them, if avapritinib does not work, you cannot give them sunitinib. You can give them another TKI inhibitor or tyrosine kinase inhibitor, such as regorafenib, which we also give for colorectal cancer. Incidentally, maybe you guys have heard it in that setting. So what about SDH deficient cases? Remember the Carney and Carney-Straczewski syndrome patients. So if you see on your specimen that your pathologist, because either you told him, which is what mostly happens, or the pathologists themselves have tested them for an SDH deficiency, you have to rule out a autosomal genetic mutation to be sure that you're not missing a syndrome. These patients, when they present, they tend to be much younger. They tend to have gastric tumors, and they can present with very large tumors at presentation. And they also have a high rate of lymphatic involvement compared to all the other patients that don't. They tend to respond to sunitinib. And it's very important, again, to not forget to test for catecholamine so you don't have a crashing patient in the operating room because you missed a paraganglioma, which can be very small and cause trouble. What about the metastatic disease? So for metastatic disease, you should start by always treating the patient systemically. So number one, you need tissue to assess what this patient has. Two, in terms of mutational pattern. Two, you need to assess where the disease is. You need to have a PET scan that will help you follow these patients and see if they're responding to treatment. You can use sunitinib as second line if your imatinib did not work based on your mutational pattern again. And you can consider resection. When do you consider resection? Very select cases. The idea is that you want to do the least harm possible, and you want to get these patients on systemic therapy, which will control the disease. So, for example, a patient that has a I missed my slides, but the patient that has a solitary lesion that can present with obstruction, in these cases, you should absolutely consider resection, or if not resection, at least a bypass. And in the other setting in the other patients in whom you should consider that is if, for example, you're giving imatinib, the patient has been on imatinib for 5 years, and now you have one disease site which stopped responding, whereas all the other disease sites are responding. So you can have a difference in clonality. And if you have a tumor or a lesion with a particular clone, you want to take that out, because most likely if this is growing while the other ones are stable, there's probably a mutational pattern that's different in it. So this is pretty much all I have. Do you guys have any questions? So I'm going to let, I don't know, Mohammed, if you want me to go through the questions, or how should we proceed?
We have one question. Is it okay if you'd like to answer it? The question is, if the lesion is not EUS accessible and the appearance is typical of GIST, would you still go for a percutaneous biopsy and take the risk of rupture or spillage?
So I think it's an excellent question. It's the question that we grapple with at all times. So for example, if you're dealing with a very small lesion that's located in the stomach and is easily accessible, proceeding to surgery the risk is not prohibitive. You should go ahead and proceed to surgery. Technically, you're performing an excisional biopsy. If we're discussing the cases where surgery has a high risk of morbidity and mortality, then I would not proceed to surgery. I would not proceed to a biopsy. So it all depends on the size and the surgery that this will entail. And that's why it's important that you work with a group that does a lot of these, because sometimes things that I think are not accessible by our US team becomes accessible. They can do push enteroscopies. They have many ways of accessing this endoscopically. If you're dealing with a tumor that requires either neoadjuvant treatment or systemic treatment for metastatic disease, then you absolutely need to biopsy this. I mean, I think that I cannot make this more clear. In California, actually, there was a lawsuit for a patient that became metastatic because he was receiving neoadjuvant treatment. They had never tested the mutational pattern, and the patient died because he became unresectable and progressed on imatinib. And again, the patient he had the PDGFR mutation. So that's why it's important to realize that if something is bigger than 5 centimeters, if you think that this is not easily accessible, please, please, please biopsy. And it can be done safely in a controlled fashion with people that do this fairly often.
Thank you. We have another question. Can there be more than one kind of mutation in the tumor? If so, is there any change in principle of management?
So it's fairly rare that you have multiple mutations. You're looking more at multiple mutations when you're dealing with patients that have recurrent disease or patients that have already been on treatment and now have this multiclonality aspect. So for example, as I described, you can have tumors that are responding really well to imatinib, and then you have 1 or 2 lesions that are not. In those tumors, you might expect that there's been a new mutation that has been added. And for those patients, you might consider doing an NGS panel, meaning that you're going to look for other driver mutations such as BRAF, NF1, even in patients that do not have an NF1 mutation, autosomal. So you want to, in those patients, you have to look for driver mutation. So when they don't respond to the treatment that you're giving them, you have something else in your back pocket that you could use, realizing that every time, like with other tumors, whenever you go to a 2nd, 3rd, 4th, 5th line of treatment, the chance of, or the time that these patients are going to spend being progression-free is going to be lower and lower every time, because they're 3rd line for a reason. If they were that good, they would be 1st line treatments.
Okay, and I believe this is our last one. If we have bleeding from a large GIST tumor, more than 20 centimeters, and nearby organs are involved, what surgical options are available?
So if you have bleeding, you have to go and resect. So all the principles that I discussed are those that are in the case of a patient where you have the luxury of time. If the patient is actively bleeding and there's no way that you can control this, either through IR therapy or angioembolization or any other method of control, then you have to go and proceed to surgery. It happens very rarely, but we've all had 1 or 2 patients where this has occurred. And in that context, you're going to go and you're going to perform massive surgery. In general, you're not even sure that this is a GIST, right? So you're going to see a mass that's involving adjacent organs. So you're going to apply the principles of of en bloc resection. If this is a slow-growing tumor where the patient is just shedding some blood here and there and is anemic and he has on and off bleeding, but it's easily controllable, you can then give these patients imatinib, and when they have the mutation, they actually stop bleeding within 2 weeks. It's extremely incredible. If the bleeding is very slow and it's occurring because of a erosion into the mucosa of this mass that's pushing the tissues from compression. But if it's an actual like massive insanguination, then only OR. And if you go to the OR, perform surgery as if this was a sarcoma, because you don't know what it is.
Thank you. Thank you so much for this informative session, Dr. Cinciano. We really enjoyed it. We appreciate you taking out the time and giving it to us. Thank you.
Thank you.
Guys, these are the QR barcodes for our next session. Our next session will be next Sunday, covering adrenal incidentinomas. It will be given by Dr. Raymond Grogan, who's an associate professor of surgery and chief of endocrine surgery at the University of Chicago. Thank you. Thank you for attending.